Hello everyone, welcome to very important TOG article, Lichen sclerosis in pregnancy, parturition and postpartum. Hello everyone. First of all, welcome you all to this session. This is for all, part 1, part 2, part 3. Lichen sclerosis is an all-time favorite of RCOG and it is good for all the parts, depending on what exactly is to be read. And that's why I decided to take up this particular session. And it's a very important topic for particularly the upcoming part 3 batch, which is just going in for their exam in next 10-15 days. Of course, part 1 and part 2 is also not far away, just 60 days away. So they also should be knowing about this RCOG favorite, right? So here we are going to talk about this new TOG article, which is lichen sclerosis in pregnancy, parturition and postpartum. That is with the point of view of obstetrician. Till now, we have got multiple times the questions about the gynae topics related to this topic, but this is first time when it has come up in the obstetrics. So in next 10 minutes, yes, you heard it right. In tune with our 70% less study time, in next 10 minutes, we will cover up this TOG articles. So be prepared, be ready, and in the end, do stay till the end because we will be having some questions. And for part 3 students, we will be having the domain-wise points as well in the end. So please stay till the end and go through it and just see that how we can finish the TOG articles so easily without putting in a lot of efforts. So here we go. We have done all the efforts for yourself so you can enjoy and relish the prepared feast. So here we go with this important TOG article. And meanwhile, I would like to hear from you, all of you, in the live chat, in so that I can just have the viewpoint of all of you and see what you all are answering. So here we go, and we start with this. So lichen sclerosis, this is basically the diagnosis and counseling, the pregnancy management and the postpartum care. All of this we are going to cover today in this session. So at a glance, if we look at the lichen sclerosis at the glance, what is basically it is about? This is an inflammatory dermatosis affecting the anogenital skin, a classical figure of 8 appearance, with the bigger circle of 8 around the perineal area, along the vulval area, and the smaller circle of the 8, the lower circle of the 8 around the anal area. So typical figure of 8 appearance. Part 2, Part 3 students know this very well. This particular typical figure of 8 appearance clue is for the Part 1 students. Prevalence is up to 3% of the population. And what are the peak ages? When there is an estrogen deficiency, right? So just remember that. Lichen sclerosis is basically occurs in the age groups when estrogen is less. So prepubertal and postmenopausal. Autoimmune association. This is very important. This is a new thing which is for autoimmune. We know, everybody knows, right? But I'm also going to talk about the genetic association. This genetic association point is certainly new for all of you, particularly when you are going to the part 3, because you will be talking about the genetic risk to the role player. You will have to explain that. So genetic association is another more important thing. Autoimmune was an old one, and that is why it is also associated with the thyroid disorders, because thyroid are autoimmune too. And of course, this figure, 5%, RCOG loves this figure. Whether it's a part 1, part 2 or part 3, this figure you always have to talk about whenever you are talking about the lichen sclerosis. So 5% cancer risk if untreated, and less than 1% with the topical corticosteroid treatment. When I say TCS, this is basically topical corticosteroids. So 5% cancer risk is there, but if it is treated, certainly this risk also decreases. So many points, beautiful points here lined up clearly in a shorter form. I still remember we have to finish the TOG article in 10 minutes, right? So classic features. What are the features? Pathological features, very important for the part 1 students. White sclerotic plaques, right? and inner labia majora, minora, clitoral hood, anything can be affected. Ecchymosis. Usually, when people look at the red patches, they usually think about the candida or the other things and do not think about the lichen in this case. But remember, ecchymosis is also an important feature, pathognomonic feature of this. So it is not only about the atrophic white patches, but it is kind of a red as well as a white, because a lot of pictures are being coming in the exam at this moment as well for part 1 and part 2 students. So mind you, how the picture is going to be, I haven't put up the picture here because of the copyright issues of the talk article, but I'm just going to tell you like how this is going to be. So sorry, I took up the white color. Let me just take the red one here so that we can have a good color visible. Okay. So this is basically how the things can be. So you will see some kind of a red patches here, but on the other side, you will have some kind of a white atrophic patches here as well. So it is going to be the mixture, right? So this is how the look is going to be. And of course, some areas will be absorbed. You will not be able to see the clear areas. So absorption of the areas, fusion will lead to introital stenosis and fissuring, which can lead to dyspareunia. Now, the first line treatment we all know is a high potent, ultra high potent steroids, which is clobetasol propionate, 0.05% or mometasone furoate, 0.1%. Now, till date, we have always been reading clobetasol. So from where does the mometasone come in? So TOG article do mentions about the mometasone as well, because it says that directly going on to the ultra potent, we can go one level lesser than that also, which is mometasone. Mometasone is also potent, but clobetasol is ultra potent. But for your exam answers, still the treatment of choice will remain the clobetasol propionate. What is the maintenance regime? A pea-sized amount you have to take, and once a day you have to apply for the next 4 weeks. After that, for next 4 weeks, this once a day goes on to the alternate days, and then it is a twice weekly maintenance regime. So this is how 3 months course is there. And for your part 3 students, we all know that one tube should last for 3 months. Now, this is genetic counseling, a new thing, part 2 exam favorite. So family risk, about 12% will have first degree relative with the lichen sclerosis. Monozygotic twins concordance in case studies have been seen, and we therefore know that there is certainly a genetic component to it. HLA associations, DQL, DQ8, DQ9, and DR12, that is the reason of autoimmune point of view, but we do not have any blood test available as of now. Markers are there in study, which you can see here in the end, examiner tip, very important for part 1 students, miRNA biomarkers. They are identified, but they are not commercially available. So we do not need to consult the patient about blood tests from the lichen sclerosis. What are the important counseling points? Small hereditary risk is there. So advise vigilance in the LS symptoms in female children. So if any role player, she has a female child, then we have to talk about being vigilant in that. Early diagnosis and treatment is the key. How does the disease course goes on? What to expect? Preconception, pregnancy, first trimester, second trimester, and the postpartum. Now, preconception, establish control. Try that the patient gets pregnancy when she is in a complete stage of resolution. So that's it. As with any autoimmune disorder. So it just goes like any other autoimmune disorder, gets better in pregnancy, and postpartum it gets worse. So in pregnancy first trimester, 44% improve. The 65 to out of 85 is the number quoted from the study which is mentioned in the talk. Pregnancy. In pregnancy, patient has to be taken care by the specialized clinic, vulval specialist clinic that will take care of it, right? So care will be shared by the vulval specialized clinics. And postpartum women, 60% may worsen in 12 months. Okay. So these lower figures are the correct values. That is 44% improve in pregnancy, 36% no change during the pregnancy, and 60% worsen postpartum. These are the treatment protocols. Clobetasol, we all know, is a safe. There is no increased risk of congenital abnormalities, preterm birth, IUGR, or fetal death. And you can continue the maintenance once or twice weekly throughout pregnancy as well. We always have read the association of steroids with the GDM and the IUGR. So do that happen with the this topical steroids as well? No. It is not with the topical steroids. Mometasone is also safe, and this is also a good option, but still this we will not consider as a first line. Calcineurin inhibitors, topical steroids, and oral retinoids, big no, not to be given. So TCS doses, low birth weight is not there. What is the mode of birth? So women with LS in labor, what are the challenges which you can face? So basically the challenge is more about the stenosis and the extensive scarring in the perineal area. If there is no scarring, no nothing, we can easily go for vaginal delivery, well controlled, well managed lichen sclerosis. If it is, yes, there is a scarring or stenosis, consider the cesarean section. Extensive scarring, patient anxiety. Basically, it is also about the psychological image. This psychological impact is a good point for the Part 3 students, where they can talk about the psychological impact on the body image and the chronic disease impact. So patient anxiety should be well dealt with. No significant increase in the obstetric tear risk in lichen sclerosis. This is very important. Coronization in the episiotomy scars. This is the lichen sclerosis can grow into the episiotomy scars or the perineal injury scars. Perineal massage as such does not have any indication, but you can do the antenatal preparation for the patient, and the manual support at the time of the delivery do matters as with any other patient. If the patient is non-compliant to the corticosteroids, then higher cesarean section rates can be there, and that actually goes because the scarring or the pain is there in that favor. So what about the postpartum? What happens in the postpartum? Why the things go worse? Because it's a low estrogen state. Breastfeeding prolongs the hypoestrogenism, and this compliance drops to 60%. Patient gets busy with the baby, so the compliance drops. Physical and emotional distraction from the treatment. And of course, the autoimmune conditions directly also worsen in the postpartum period. So what we need to do? Continue or restart the corticosteroids. We can add the low dose vaginal estrogen here for the vulvovaginal atrophy. This is safe, absolutely safe. This estrogen does not go to baby, so we can go carry over that. Over 30% postpartum depression in lichen sclerosis patients. So screen proactively. Very important point, very important point. Postpartum period mental health issues. Suicide is the biggest factor here. So basically postpartum depression, very important. What are the red flags to watch of? Pruritus, burning, tearing, hypopigmentation is worsening, labral agglutination and a clitoral phimosis is happening, or the patient is having the dyspareunia. She should report back for the contact numbers. Something about the vaginal estradiol. Is it safe with the breastfeeding? Yes, it is absolutely safe. There should be no fear factor. So both transdermal preparations, that is 50 to 100 microgram patches, and the vaginal estradiol, which is 50 to 100 milligram vaginal estradiol, both are absolutely safe. So patches are also safe, and the estradiol application is also safe. So what is the practical protocol to be followed in the postpartum period? Continue the corticosteroid management, add low dose vaginal estradiol cream to intritus, perineum if atrophic symptoms. Apply avoiding intravaginal insertion initially. Initially, you can start applying the outer areas, and then as you go further, you can apply intravaginal. And lower introital application, less systematic absorption than high vaginal placement. 94% of the patients reported receiving insufficient information about breastfeeding. So you be the clinician who bridges the gap between the insufficient information and a properly informed patient. And you are the one who is going to cover up this. So yes, we finished it in 10 minutes. I think it's less than 10 minutes. So let's talk about some questions. Okay. So what are the options here? Clobetasol propionate 0.05%, vaginal estradiol cream, tacrolimus ointment, cesarean section, vaginal delivery, stop the topical corticosteroids immediately, or the oral retinoids, genetic screening, or the genetic screening blood test. So these are your options, right? Now, what is the first question? Let me just look at the chat so that I can know who is the fastest finger first. And I would certainly like to announce the name here. So yes, very good. Oh my God, so many students here. Oh, very good. Great. So yes, good evening. Very good evening. Yeah. So yes. So 28-year-old with a known lichen sclerosis on maintenance, clobetasol twice weekly, is 10 weeks pregnant. She is worried about continuing her steroid cream. What is the most appropriate advice? 28-year-old with known vulvar lichen sclerosis on maintenance. She is worried about continuing her steroid cream. She is 10 weeks pregnant. So, what is the most appropriate advice? What is the most appropriate advice? So, yes, perfect. Dr. Radhika, fastest finger first. Great. Yes, others are also doing it right. Dr. Deepti, Dr. Yashli, and Dr. Rehta. So see, you all have learned lichen sclerosis so quickly, so quickly. Yeah, that's the beauty of these sessions, Dr. Mehnaz. So yes, A is the correct answer. Now going on to the next question. 32-year-old postpartum, 6 weeks breastfeeding, presents with worsening vulval pruritus and dryness. 32 weeks postpartum, 6 weeks breastfeeding, presents with worsening vulval pruritus and dryness. She's dropped her TCS in the pregnancy due to fear. Examination shows no active infection. What two treatments would you recommend? What two treatments would you recommend? Ideally, there is no option of two treatments, but yes, you can pick up two options. I think that would be the best as well. So you can pick up actually two options because there is no option where two treatments have been combined. Yes, looking for the correct answer from you all. I know you all are going to do it good. Yes. So B, yes, A and B both, because we are going to choose two options here, right? So there's Dr. Naidu. She got the answer right. A and B and B and B. Yes, good. Yes, Dr. Deepti, Dr. Yashli, and Dr. Rohita and Dr. Himanthi again. So here comes the third question. Pregnant woman with poorly controlled LS, that is extensive labial fusion, significant introital stenosis at 38 weeks, discuss the mode of birth. What is the recommended approach? What is the recommended approach? She wants to discuss the mode of birth, and there is extensive labial fusion and significant introital stenosis. Now, what to do in this case? What to do? Yes, this is an indication for cesarean section. So, cesarean section should be considered where extensive scarring would make vaginal delivery unsafe or cause significant patient anxiety. So that was for the part 2 students. And then now something more about the domains. Like part 3 domain framework. How will you adjust this information into your various domains? Now, what could be the presentation of the patient? Either she can come directly as a known case of lichen sclerosis and wishes to discuss about the pregnancy options, or she can come with the dyspareunia, and then it goes on to lichen sclerosis and she wants to discuss about the pregnancy. So these could be the two possibilities here. So when I talk about the information gathering, what all we need to have? So current lichen sclerosis treatment and what is the compliance? What is the assessment like introital stenosis, scarring, what all is there? What is the breastfeeding intent of her, mental health, anxiety, and childbirth? So this is very, very important. If there is any previous deliveries, then what was the mode of delivery? Was there any complications, any tear, any episiotomy which was given? Also, you can, in cases of dyspareunia, you would also consider the history of dermatitis, contact dermatitis, and other infections in the previous period as well. So that all we need to look at. Then when we go on to the examination, it is important to examine what exactly it looks like. Is there any erythema or there are any fissures? So these all things we will look right to. Any scar tissue, what about the condition at the vestibule? Because the important differential diagnosis for the lichen sclerosus will be vestibulodynia or the vulvodynia. So that will be a good thing here. Or it could be simple candidiasis or the infective conditions because you will have a young stage patient. So examination will be very important there. Now, what are the patient safety points? Confirm that the topical corticosteroids is safe in pregnancy because usually the patients come with a phobia for the drugs. Identify poorly controlled the lichens process early because, as I said, the malignancy risk is also more. And the secondly, these patients may have land up into cesarean section also. So we need to properly treat that. Cobrinarization risk at the episiotomy site, that is the development of the lichen sclerosis at the episiotomy site. This is a very important point and a very important patient safety point to be told to the patient. Screen for postpartum depression, another, because mental health, you all know how favorite is that for RCOG. Communication, reassure that the pregnancy outcome is not dependent on the severity, right? It is significantly good. Explain inheritance risk in simple language. There is a 12% inheritance risk, so you need to talk about the female child, if any. Discuss 94% has the insufficient information gap. Therefore, address that breastfeeding is safe with the estrogens. Apply clinical knowledge, talk about the regime, the dose, frequency, agents. Or if you talk about the lichen sclerosis exacerbation in the postpartum period, and we talk about the differential diagnosis, as I have mentioned that genital sexual dysfunctions, they can be part of it. The mode of birth decision making, when the vaginal delivery and when the cesarean section, and low dose vaginal estradiol is safe in the pregnancy. So these are the various factors which will be important in this particular case. So recommended management will include, you need to discuss about the postpartum dyspareunia and its causes, and specifically tell her that the treatments can actually increase the, make the condition better, because dyspareunia is going to be the problem. So psychosexual counseling will be another important issue thing here. Granulation tissue, if she comes with the granulation tissue, then you have to either you can do the silver nitrate, and very rarely you can go on to the excision. For atrophy, we have already talked about the vulvovaginal atrophy. And if there is a pelvic floor dysfunction, then we can go for physiotherapy. So looking at all of these together can make the patient fit and can bring you the success. Absolutely good case presentation in your part 3. So these are a few high-yield summary points. It is autoimmune. Only 12% have family history. And as of now, we do not have any marker for screening. miRNA is the marker, which is in experimental stage. Topical corticosteroids are safe in pregnancy. No congenital abnormalities, preterm birth and IUGR. So remember, you are not going to talk about the SGA in cases of topical corticosteroids. 44% improve in pregnancy, 60% flare postpartum. So postpartum period is the worst for these. Mode of birth is usually vaginal delivery. We take care about the extensive scarring and the major anxiety. In postpartum period, you can continue the steroids along with vaginal estradiol, and it is safe in breastfeeding. No need of calcineurin inhibitors or oral corticosteroids. And if the patient is on topical corticosteroids, stop at least 1 month before in the preconception. Genital urinary syndrome of lactation, treat with the estradiol. 30% risk of postpartum depression, so mental health is very important, and 94% women are not properly informed, and you will be the one clinician who will be informing all of these women and be the best among all the crowd and be on the top with MRCOG courses. So for all those students who have not yet enrolled with us, although I can see majority of the students are our enrolled students who are in the session, but those who have not enrolled till now, they should now stop guessing and start passing in a 70% less study time. So if you haven't done so, this is a QR code. You can scan and start immediately. We have recently started, like only from the 15th April. So you are very, very new. So no worries. And for those who are looking for the part 3, we have a very beautiful surprise. Very beautiful surprise for all those who are going for part 3. What? For every session, you will be getting a proper written feedback after every station presentation in the live session. Guess what? It will have a clear marks, borderline pass. It is not only about that. It will give what went well, what you did not do good, and what are the target recommendations looking at that performance. And you see, every class you get this. So how beautifully you can get better. So exactly examiner like points, sheets, and the same feedback, not just verbal, but a good written feedback which you will receive in your mails. So that's all we are going to get. So those who are now starting for November, and I think it is a high time to start for November, because otherwise the time will be less and you need some time to prepare. So that is why it is like you can go ahead with that. Okay, fine. Any queries or any questions? The session is open. And as I promised, I have finished the TOG article in 10 minutes. Just although we were discussing the questions and the domain points. So now I'm good to go with the questions. Anybody has any questions or wishes to have some information? Yes. Your questions are welcome, and you can also leave the feedback in the chat box as well. And also let me know whether you like this shortcut way of studying, so that I can take up more TOG articles. And if any specific topic which you feel is difficult and you want me to take and summarize it in 10 minutes, just let me know and I'll do so for you. So you can leave the topic in the chat box as well. Okay, yes. Looking for questions, if any. Yes. Yeah, that's the new batch is starting very soon, right? Very soon. Part two crash course is already just we have started. We have done only one this thing, and the part three batch is going to start. We have our phone numbers here. We have our website address here and email address here. You all can take the screenshot and get back. You can get back to us on these numbers if you have any questions. Okay. So, yes, bye bye, take care, and have a nice evening ahead. And we'll keep on practicing like that. How is LS for MRCOG part 2, ma'am? Okay, Dr. Imanti, LS is very important. Till now, the questions were coming only about the gynae like percentage, but this time the new TOG article about the obstetrics is there. So it is very important. Oh, yes. Thank you so much, Dr. Gigi Shah. Very well explained, easy to remember. Yes, I'm pretty sure you are not going to forget. And when you have this question in the exam, do remember me. That will be there, right? Lichen sclerosis and gynecology, we all have been always reading, but this is something about the obstetrics, which is the new thing here. Yes, thank you. Thank you, everyone. Thank you, Dr. Deepti. Thank you, Dr. Mehnaz. Thank you, Dr. Francis. Thank you, everyone, for joining in this lazy afternoon, hot afternoon. Actually, we are here and have a very, very hot afternoon. And still, you all are awake with the session. So that's my pleasure. Thank you so much for joining in and looking forward to see you in further sessions as well.